I thank everybody for being here today, and thank all our two author guests that are here today. It's awesome to have you guys here. We are so honored for your presence, and we thank the residents who worked hard to put on the to review these articles and to teach us something today. So this is just such an honor and fun thing to have. This is a very unique opportunity to kind of combine multiple programs into one venue. And then we'll leave Dr. Christmas from ACP. I'd like to say just a few things.
Good afternoon, everybody. Welcome. So glad to see so many faces here joining us. And thank you for giving me the chance to acknowledge the Maryland ACP. We have such an incredible, I'm just going to say it. We have the best chapter in the world. We really do. We have like such an amazing chapter. So if you're not a member of the ACP, come on, join us, reach out to me. I'm happy to get you connected. If you want to join any of our committees, we have a lot of activities. I personally feel so grateful to our members and our chapter for all of our fantastic educational offerings, our advocacy, both at the state and the national level, our community service events, our professional development events, on and on and on. There's a lot going on that I feel so grateful to be part of as the current governor. I also want to give a special shout out to the folks that have worked really hard to put together this multi-residency program journal club. I think it's really cool. Dr. Fergahi has been really taking the lead on it with support from Drs. Weissman and Chow and Mugolinskaya. And I'm probably forgetting somebody. And if I did, please give a shout out there. And then the last thing I'll say is that I'll drop a few things in the chat that are ACP opportunities as we go through. But at any time, if you want to reach out, feel free. I'm happy to support you. Thank you all so much.
Thank you.
Wonderful. Thank you very much, Dr. Christmas, Dr. Weissman. It has been impossible without your mentorship. We really appreciate your support. Today, I'm very happy to introduce our guest speakers of the two very pragmatic trials, Dr. Roland von Kimmenade and Dr. Signe Glargaard. Dr. Kimmenade is cardiologist and heart failure investigator at the Radboud University Medical Center in Nijmegen, the Netherlands. He is heart failure researcher with long-standing work at the intersection of heart failure, renal function, and biomarkers in acute and chronic heart failure. He is the principal investigator of the Fresh Up trial presented at ACC conference this year and published in Nature Medicine. Dr. Glargaard is doctor at the Department of Cardiovascular Research at Basberg University Hospital in Copenhagen, Denmark. Dr. Glargaard's primary research area is heart failure and pathophysiology and treatment in heart failure-related pleural effusion. She is the coordinating investigator on TABIT trial, which investigated the prognostic effect of upfront thoracentesis in acute heart failure. It is also published highly in Circulation. Dr. Kimmenade and Dr. Glargaard, welcome to our session.
Thank you very much.
Thank you for having us.
Our presenters today are Dr. Tamila Rezayeva and Dr. Abisha Dawa from Anne Arundel Medical Center, Dr. Su Yong Huang from University of Maryland, Midtown campus, and Dr. Mediha Kiani from MedStar Health. Thank you all for your hard work to prepare for this presentation. I've shared the QR code for the event. Please feel free to scan it in your cell phone. And at the end of the session, please submit your responses. Now I'm going to unshare my screen. And Abisha, do you want to start sharing?
All right. So let me just make sure. Can everyone hear us okay?
Yeah, I hear you okay.
All right, perfect. So friends, colleagues, esteemed guests, we're very happy.
What does everybody say? I'm seeing Fresh Up as the study on there.
Okay.
Is that just my screen?
I don't see the screen. Do you want to share your screen, Abisha, again, please?
Yes, we'll try sharing again, and then how about now?
That's it.
Yes.
Perfect. Perfect. Thank you.
So no Zoom call would be a Zoom call without a little bit of troubleshooting.
Absolutely. Well said.
So again, friends, colleagues, esteemed guests, thank you all for coming here. My name is Abisha. I'm joined by my co-presenter Tamila, and we're happy to talk about the TAPID trial, also known as a randomized controlled trial of fluorescentesis and acute heart failure. So I think before we really get into the meat of the trial itself, especially when we're surrounded by so many learners, behooves us to kind of talk about some of the underlying pathophysiology of the disease we're looking at. So with pleural effusions, I think it's important to kind of go over some of the underlying mechanisms because it's certainly important and relevant to the trial we have today. With pleural effusions, we know in heart failure specifically, there is increased hydrostatic pressure, and this can lead to increases in other filling pressures in the body, like pulmonary capillary wedge pressure and central venous pressure. For patients with acute heart failure and chronic heart failure, as is often the case with these diseases, they have poor nutrition. This can lead to low albumin and subsequently low oncotic pressure as well. This combination of increased hydrostatic pressure as well as this low oncotic pressure leads to this fluid extravasation. But the underlying mechanism does vary a little bit by which side of the heart we're looking at. From the left side, we know in left ventricular failure, this can lead to a increase in left ventricular end diastolic pressure and subsequently an increase in left atrial pressure. That left atrial pressure as well will lead to a subsequent increase in pulmonary capillary wedge pressure, more in filtration of fluid, and subsequently movement of fluid from the visceral pleura to the pleural space, again ending in a pleural effusion. On the right side, the underlying mechanism is a little bit different. We know with right ventricular failure, you have more of an increase in central venous pressure and a lot of systemic venous congestion that leads to impaired lymphatic drainage, as well as eventually increased parietal pleural capillary pressure, and all roads again leading to movement of fluid into the pleural space and subsequently pleural effusions. So we know actually that this isn't just in theory and underlying pathophysiology, but in fact, this has actually been looked at more objectively. So Dr. Glargaard as well was one of the main authors in a trial that was looking at patients who had, as part of a normal heart failure workup, had right heart catheterization and found interestingly that some of the filling pressures we were talking about, this pulmonary capillary wedge pressure and central venous pressure, were actually associated with the size of the pleural effusion, and not just more of a just association, but actually they found a sort of dose dependent relationship for each 1 millimeter mercury increase in pulmonary capillary wedge pressure. The odds of having a pleural effusion in those patients went up by 6%. For each 1 millimeter mercury increase in central venous pressure, the odds went up by 9%. So again, the study suggested that there is this relationship between these filling pressures and the effusion sizes. So we thought that was very important, and we wanted to touch on that briefly. So now that we've talked a little bit about the underlying pathophysiology, let's move on to kind of talking about what we do about it. And I think something interesting to note is that while we're always worried about, modernization in medicine, sometimes it's nice to look at the historical context. Actually, a lot of what we do isn't as modern as we think. Hippocrates, really, as early as the 5th century, was described as using a procedure where he would use a trephine or this needle at the ribs to pierce the lung and to remove fluid. And, this isn't a 5th century photo, but this is actually the top photo is from a monastery drawing of a physician at that time, what looks like a mid-axillary approach to draw fluid off. And interestingly enough, it wasn't just in that part of the world. Dr. Seraphine, he was a Turkish physician in the 1400s, also had an illustrated surgical textbook where he described something similar, where he would actually go through the intercostal space for drainage of an empyema. And this is actually the bottom photo is a photo illustrated by that Turkish physician himself, where again, it looks like they're using a mid-axillary approach. So I just think it's always nice to remind ourselves sort of where these treatments and procedures came from. For a more modern look at it, we know that thoracentesis is a very, very common procedure. Upwards of maybe 200,000 of these procedures are done every year based off of Medicare and procedural data. And we know that there are several indications for this, including, heart failure patients with persistent effusions, unilateral effusions, or effusions with atypical features. And we know just from the references in the study and as well as our own research that, more than half of the patients with acute decompensated heart failure actually present with these pleural effusions. So why do thoracentesis? We know for a lot of patients, it provides them rapid relief of their symptoms, especially shortness of breath. In many patients, it can improve their oxygenation. As we already demonstrated from the previous slides, a lot of the filling pressures and the underlying cardiac and respiratory hemodynamics are affected by these effusions. So as we get rid of them, that can sometimes help cardiac filling and stroke volume. For something that is seemingly has a lot of benefits, the actual guidelines around it are a little bit vague. The incidence of thoracentesis and heart failure has been increasing over the years, but when you look into it, there's actually no established guidelines for thoracentesis and heart failure related pleural effusions. Not really anything specific from the AHA, the European societies, the ACC. So we know that a lot of heart failure patients have these pleural effusions. We know that some get benefit from thoracentesis, but when to tap, where to tap, how to are all questions that are still up for debate. So that really brings us to the trial itself.
Yeah. So it's my honor today to walk you through the trial, which is considered TAPA trial, which will be like first randomized control trial and was studying like how upper thoracentesis in heart failure related pleural effusions. So study was pragmatic, multi-centered, open labeled, and was held across the 10 cardiologist centers in Denmark, including 3 tertiary cardiology centers from August 2021 till March 2024. What was the hypothesis under this trial? So referring hypothesis was that referring patient with sizable pleural effusion heart-related to upfront thoracentesis increases the days alive and out of the hospital in the following 90 days. Who were included in the study? So adults age 18 and above with heart failure and left ventricular ejection fraction of 45% and less. This was done in attempt to capture effusions with highest chance and probabilities that it's related to heart failure and not other etiologies. Other important inclusion criteria was size of pleural effusion, which should be large enough to be drainable and cause some symptoms. When it comes to exclusion criteria, the main exclusion criteria were the diagnostic thoracentesis, if patient had contraindication to thoracentesis, hemodynamically unstable patient, including blood pressure of less than 85, and also a patient with severe respiratory impairment, and if patient had massive pleural effusions, that was exclusion criteria. Other noted exclusion criteria were severe aortic stenosis, if there is other suspected etiology of pleural effusions, including malignancy, infection, patient on dialysis, and overall severely impaired renal function, and patient who had prolonged admissions. When we go to the study design, so patients were screened by treating physicians during admission, and they were randomized 1-to-1. The randomization was stratified by site and anticoagulation use status. We had 2 groups, which one is a control group with standard medical therapy versus an intervention group with intervention thoracentesis, upfront thoracentesis plus standard medical therapy. And the discharge was managed by treating physician discretion. There were assessment of quality of life based on Kansas City cardiomyopathy questionnaire at 14 days and 90 days. So primary and secondary outcomes of the trial, with primary outcomes being the days alive and out of the hospital in 90 days after randomization, just to reflect overall health burden. And key secondary outcomes were 90 days all-cause mortality, as well as quality of life and duration of index admissions. Study population.
So there were 136 participants with equal, as we mentioned, 1-to-1 randomization of 68 getting control and 68 patients getting intervention. And intervention arm was like 59 patients out of 68 underwent thoracentesis, and the rest 9 did not, just because they didn't have sizable trainable effusion. And other important thing that median was from between the admission, randomization, and thoracentesis was 22 hours. Overall, median of 1,000 milliliter of fluids were removed from the patients. And in control arm, 62 out of 68 received the medical therapy only. When we checked the baseline characteristics of the patients, it was noted that median age of participants were 18 years and older, and about 30%, which is 1/3 of them, were female. 50% did receive anticoagulation therapy. Selected patients, they had very high pro-BNP at baseline, and 53% of them had new onset of heart failure. What was the primary outcome results? Looking at these predictions, we can that there is no difference in the distribution between the groups, its control and thoracentesis groups. When we check the secondary outcomes, specifically index of admission, they were also similar between the two groups, which with median of 5 days. So it looks like the faster relief of symptoms was not associated with rapid discharge. Other secondary outcomes in hospital mortality and 90 days mortality were also similar between these two groups, with 3% in hospital mortality and 13% in 90 days mortality in both groups. So no difference there. And also showing the results of the Kansas City questionnaire, it looks like response rate, all the response rate was low, 50-60%, but both the total summary score and clinical summary score were assessed, and there were no difference in this questionnaire as well.
So as we continue to talk about the trial, it's always good to look at the limitations as well and areas for further research. Of course, this was an open label trial and there's no blinding. It's very difficult to blind a patient when you are putting a needle into them. So understandably, it was unblinded, but obviously that can introduce some bias into the results. The other thing that they looked at was their moderate effusions only. They excluded large effusions, so again, taking up more than 2/3 of the thoracic cavity. Some of these larger effusions sometimes are associated with more symptoms, so it's possible that might have influenced things. The other thing is that this only really looked at patients with low ejection fraction, so there was no heart failure with preserved ejection fraction patients. Certainly that may limit the kind of how we can extrapolate this to some of our patients. The median age, again, was 81, and these were, again, more frail patients when you look at the baseline characteristics of the participants in the group. So again, extrapolating that to our increasingly younger populations that we're seeing heart failure in may be a little bit difficult. Understandably, because this was a pragmatic trial and also ethically, if patients were not improving on just standard treatment, they did have the option to be part of the thoracentesis group and get thoracentesis, which again is ethical and important for patients. However, sometimes that crossover design may have diluted treatment effects between the groups. In conclusion, with this type of trial, it looks like that based off of everything we're seeing, there was no significant difference in overall out-of-day hospitalization 90 days and, quality of life looking at the Kansas study. So we would recommend, avoid routine upfront thoracentesis.
Was this one for Tom's
With moderate pleural effusions when no alternative etiology is suspected. And, as we previously discussed, prioritizing GDMT and diuresis as initial management is what we would say looking forward. Of course, there's always room for more research, but based off of what we saw and what we read, this is what we would conclude. So these are our references.
Excellent.
Thank you very much.
Dr. Glargaard, of course, we want your opinion on your study, and I'm curious if you had to do it again, would you do it differently in any way? I think of the 3 studies we're presenting, this is the oldest population and looks to be most frail. Just some comments from you. What do you think?
Thank you very much for the very nice overview. I'm very proud. Thank you. I think you captured a lot of the positives and a lot of the strength of the study, but as well also pointed out some of the things that we would have done differently. I think in a bit that Roland would tell us as well, when doing a pragmatic study on an intervention that is already implemented in the clinic, the very difficult part is to convincing the investigators and the clinicians participating in a trial where the setting is pragmatic, is to stop doing what they're used to doing. So a lot of the exclusion criteria was based on consensus in the steering committee or the investigator group in order to make sure that people could adhere to the protocol. Especially right now, I think the thing that I regret the most is the exclusion of the larger effusions. I would like to point out that only 2 patients were excluded based on that exclusion criteria, because if you do look at an X-ray of the thoracic cavity, then over 2/3 is a lot. So we do have, I would sort of disagree on the point that we do not have larger effusions, because you can see on the amount drained that a median of 1 liter is still what I would say a clinically relevant effusion size, but it looks different on an X-ray. So of course, now in the hindsight, I would have loved to be more bold and to include those patients in the trial as well. But maybe that's also why we needed the TAPIT trial, to sort of see, okay, well, this is safe. Maybe now we can take it a step further. The second thing is that like Roland as well with the Fresh Up trial, it's a strategy. It's very difficult to test the efficacy of a thoracentesis, because I cannot force the drain in the patient if they, after a relevant pause of 2 days of anticoagulant treatment, do not have enough fluid. So maybe the crossover is, it could have sort of maybe disguised a different, but if you look at it in another way, maybe this is also the result you get from referring a patient to an intervention that has to be postponed for 2 days. And maybe in those 2 days, the diuretics actually worked. So I think that's also the other bold thing I would have liked to try was to maybe refrain from the pause in anticoagulant treatment, because there are a lot of safety studies and meta-analysis now on the complication rate of thoracentesis that underlines that it is a low bleeding risk procedure, and that it is also safe in patients with on anticoagulant treatment or with coagulation disorders. However, I would also say this is why we did the TAPIT trial. It's because in thoracentesis, as you say, I like the historic perspective. It's an historic procedure. We do it a lot. We do it at MHIM. We do it in the malignant pleural effusions. And there the indication is different. But in the isolated heart failure population, there is an alternative non-invasive treatment. And that's what we wanted to try to emphasize, that maybe because we have a history of draining pleural effusions and other etiologies in heart failure, there are other ways to reduce congestion and reduce the filling pressures. And that's with guideline-directed medical therapy and also diuretics. So when doing an invasive procedure, even with a low risk of complications, it should be tested in a randomized trial, and it has never been done. So that's the sort of the beginning of TAPIT. And also, I think it comes from a clinical question where, at least in Denmark, the practice is different across departments. If you ask one attending, they will say this one thing. If you ask another, they would say no. So when there's this discrepancy, that's often because we do not have a lot of evidence and we do not have clear guidelines. So that's what that was the main point of the study. And thank you very much for a very nice presentation.
Dr. Glargaard, thank you for your input there. That is so valuable. And I think this may, change how people approach heart failure, and especially in patients with pleural effusion. So such an important article to add to the medical literature. And I know that putting together a pragmatic study such as this is no easy task. So
No,
it's tears, I'm sure, I went into that study. Thank you so much. And if you could stay on, we'd love to have your input as we go on for the other studies as well.
Thank you.
Thank you so much. If we're going to go to the sodium HF trial, right? With that, Signe?
Yes, I'll start sharing my slide.
Thank you.
Can you guys see my slide of it?
You're in the not the presenter's mode, at least what I see. It's just, yeah. No, it is. That's perfect. Thank you.
Okay. So just give me 1 sec. Hi, I'm Soo-young, and I'm a third year and chief resident at the University of Maryland Midtown campus. And today I'm going to present the sodium HF trial. So the sodium HF trial, or the reduction of dietary sodium to less than 100 millimoles in heart failure trial, is an international open-label randomized controlled trial. For your reference, 100 millimoles is around 2.3 grams of sodium. Restricting dietary sodium is a common non-pharmacologic treatment for heart failure patients with symptomatic congestion. For example, in our hospital, we will frequently order the sodium restriction diet for patients, which restricts their total sodium to a daily intake for 2 grams for patients with heart failure. However, specific recommendations are based on low quality evidence in general. In general, the AHA recommends reduction of sodium intake to less than 2.3 grams per day for general cardiovascular health promotion. There is also a moderate recommendation with limited data for the following. For patients with stage 3 heart failure, avoiding excessive sodium intake is reasonable to reduce congestive symptoms. The traditional idea of sodium restriction is based on the fact that heart failure leads to neurohormonal activation and impaired autonomic regulation, resulting in sodium and water retention. Low sodium intake was thought to cause intravascular volume contraction, improving hemodynamics and reducing congestion and myocardial wall stress. However, it may also lead to a vicious cycle of increased sodium and water retention through the neurohormonal activation secondary to intravascular congestion, leading to decompensated heart failure. Several studies have previously explored the effect of sodium restriction in heart failures in various ways. For example, a 12-week prospective RCT in 97 patients showed that sodium restriction to 2 to 3 grams a day improved the NIHA functional class and leg edema in HFrEF patients. In another randomized trial of 75 patients with acute decompensated heart failure, restricting fluids to 800 milliliters per day and sodium to 800 milligrams per day for up to 7 days or until discharge did not result in significant difference in the weight loss, clinical congestion, or readmission. 2 recent randomized trials examine whether sodium restriction improved clinical outcomes or quality of life in patients recently discharged from the hospital using provided meals to support adherence. The first one is the Prohibit Sodium pilot trial, where patients were randomized to either a 1.5 gram sodium meal versus a 3 gram sodium meal. And during a 12-week follow-up period, it showed that the 1.5 gram sodium meal reduced urinary sodium and improved the quality of life, but no improvement in clinical outcomes or difference in NT-proBNP levels. The second trial is the Gourmet HF trial, where patients received a 4-week home-delivered sodium-restricted meal, which limited sodium restriction to 1.5 grams a day. This study also showed that there was a non-significant increase in the KCCQ clinical summary score, which it reflects quality of life. Although sodium-restricted diet sounds relatively benign, there are certain downsides to it. For example, sodium restriction can result in poor dietary quality with inadequate micro and macronutrients. Also, reducing dietary sodium is difficult to achieve in patients, even with prepared meals or home visits. In this study, the investigators aimed to explore the dietary effect that correlates to actual clinical outcomes in patients with heart failure. This was a multinational RCT in 26 sites in 6 countries. Patients were eligible if they had NIHA class 2 to 3 heart failure and were receiving optimally tolerated GDMT. Patients were excluded if they already had a low average dietary intake of sodium, hyponatremia below 130, advanced kidney disease or ESRD, or if patients were admitted for a cardiovascular cause within the past month. As it was an open label trial, the investigator, participants, and clinicians were aware of the assigned treatment strategy. However, randomization and data collection were done centrally, and the clinical events committee, who adjudicated all results, including hospitalizations and ED visits, were masked to the trial group assignment. Meal plans and menus were tested in a pilot study and adapted to regional diets, as it was performed in multiple countries. And participants received 6 daily sample menus tailored to the degree of sodium restriction while maintaining a normal caloric diet. The low sodium diet was assessed using a 3-day food record for a sodium target of less than 1.5 gram per day, while the control group received general advice to restrict dietary sodium. And there was no restriction in fluid intake in both groups. Patients underwent a total of 12 months of intervention and were followed up for an additional 12 months. Clinical visits were performed at baseline, 6 months, and 12 months, and the interventional group had an extra visit in 3 months and 9 months. Vital signs, body weight, 3-day food record, NIHA functional class were measured, and the dietary sodium intake, as mentioned, was assessed using a 3-day food record. The primary outcome was a composite of cardiovascular-related hospitalization, cardiovascular-related ED visits, all-cause deaths within 12 months after randomization. The secondary endpoints were time to first event of the individual composite outcomes, the quality of life measured by the Kansas City Cardiomyopathy Questionnaire, the clinical summary score, the physical limitation score based on the KCCQ questionnaire, change in 6-minute walk distance, and change in NIHA functional class. Analysis report performed using an intention to treat approach in which all patients were included in the groups to which they were originally randomized. Pre-specified subgroup analysis of the primary composite outcomes were performed in terms of age, sex, NIHA class, calorie intake, sodium intake, ejection fraction, BMI, and eGFR. A post-hoc sensitivity analysis was also performed. Between March 2014 and December 2020, a total of 806 patients were enrolled and randomly assigned to either a low sodium diet or usual care group. Data on race and ethnicity were not collected. The median age was 67 years and 66% of the patients were men. 68% of the patients had heart failure for at least 1 year before enrollment, and 33% have been admitted to the hospital due to heart failure in the past 12 months. The median ejection fraction was 36%. At randomization, 81% of the patients were receiving an ACE/ARB or a combination sacubitril valsartan pill, 87% were receiving a beta blocker, and 57% were receiving a mineral receptor corticoid agonist. At baseline, the median sodium intake was 2286 milligrams per day for the low sodium diet group in red, and 2119 milligrams per day for the usual care group. In the usual care group, at 6 months, the median sodium intake was 2021 milligrams, and at 12 months was 2073 milligrams, leading to an approximately 4% decrease from baseline to 6 months and from baseline to 12 months. In the low sodium group, at 6 months, the median sodium intake was 1649 milligrams per day, and 12 months was 1658 milligrams a day, leading to approximately 28% decrease from baseline to 6 months and from baseline to 12 months. There was no significant difference between the groups in body weight, systolic blood pressure, calorie intake, fluid intake, or potassium intake up to 12 months. Within 12 months, the primary outcome has occurred in 15% of patients in the low sodium group and 70% in the usual care group. There was no statistically significant difference in terms of all-cause mortality, cardiovascular-related hospitalization, and cardiovascular-related ED visits. The results were similar when adjusted for age, sex, NIHA class, baseline calorie intake, baseline sodium intake, ejection fraction, BMI, eGFR, and the presence of ICD. The increases in the overall summary score, the clinical summary score, and the physical limitation score on the KCCQ questionnaire were significantly greater in the low sodium diet group than in the usual care group between baseline and 12 months. However, there was no difference in the 6-minute walk test at 12 months between the two groups. There was a significant difference between groups and NIHA functional class at 12 months, with the low sodium diet group having a greater likelihood of improving by 1 NIHA class than the usual care group, with an odds ratio of 0.59. This study is the largest trial to date to explore the clinical effect of dietary sodium restriction, with longer than most short-term feeding studies. In order to maintain a real-world pragmatic design, investigators implemented a menu-based approach rather than specifically prepared foods. This design facilitates translation into clinical practice with dietary intake tracked using 3-day food records. There were no alterations in calorie or fluid intake or other supplements in order to modify sodium alone. Also, the sodium HF trial enrolled patients in an ambulatory setting where patients were recruited at least 1 month after a cardiovascular hospitalization to avoid the vulnerable period immediately after discharge. There are also several limitations to this study. First of all, due to masking being very difficult, patients were not masked to study group assignments, which can lead to bias in areas such as the patient-reported quality of life. However, the clinical outcomes were still centrally adjudicated. Also, there is a possibility that some patients may have decided to reduce their sodium intake in the usual care group as well. But there, as I mentioned, there was a significant difference in the sodium intake after 12 months between the two groups. And due to limited resources, there was no data on urinary or other biomarkers. And also, the trial was stopped prematurely due to the COVID-19 pandemic, which created operational challenge, and a planned interim analysis suggested that the trial would likely show futility. Lastly, the eligibility was mainly determined by the clinical diagnosis of heart failure. To summarize, this study was able to demonstrate that dietary sodium restriction less than 1.5 grams per day in heart failure patients in the ambulatory setting did not reduce the clinical composite outcome of all-cause mortality, cardiovascular-related hospitalization, or cardiovascular-related ED visits. However, there was improvement in patient-reported quality of life and clinician-assessed NIHA functional class, with a caveat that there was still no significant difference in the 6-minute walk test. The study ends by recommending dietary interventions as well as other pharmacal interventions on an individual basis. These are my references, and thank you for listening.
Awesome job. That was fantastic review of that article. There was a question in the chat about excluding hyponatremia patients.
So the cutoff is pretty low for excluding hyponatremia patients. Is sodium below 130?
Yeah.
Which I do think is a little bit reasonable to modify confounders.
Now, and I would love to hear our guests' interpretation of this trial as well. Now, from my calculation, there was about a 415 milligram difference in sodium between the two groups. Does that sound right?
Yes.
Is that enough to see a difference with that very, what is that, a quarter of a teaspoon, I think, of sodium difference between the two groups? I throw it out there for you. I don't know.
What I found a little bit odd was that the title mentioned that it was a trial recommending below 100 millimoles, which is 2.3 grams. But their conclusion is that the low sodium restriction of less than 1.5 grams is what they actually explored. So based on the AHA guidelines, less than 2.3 grams is still the general recommended restriction for general cardiovascular health. But the question would be, will more optimal restriction to 1.5 grams actually make a difference?
Exactly. Well said. Well said. Dr. Kimmenade, Dr. Glargaard, I'm curious if you have any opinions on this. I know you're familiar with this study.
Yeah, I think
it's a landmark trial for pragmatic trials. I mean, I'm good friends with Justin Ezekevich, so I know how he struggled to perform this study. It was prolonged for several years, and the problem especially was to recruit patients. And I think that this is also one of the limitations of the interpretation of the data, because well, you can see in this trial that the patients that participated are those who are really interested in lifestyle, health, a healthy lifestyle, etc. So what we're actually looking at is at a low sodium intake versus a very low sodium intake.
Exactly.
And that makes it very difficult to extrapolate to daily practice, because I assume it's the same in the United States, but my patients do not naturally only take 2,300 milligrams of sodium intake a day. So that makes it more difficult. And what's also exemplary for a pragmatic trial is that he had to advise a diet. So, which is of course multifaceted. So, if you would start your day usually with a taquilla and a sniff of salt, and you would exchange that to a spinach smoothie, then it's not only the sodium that makes the difference. And this is of course very difficult to filter in these results. But in the end, I think they did a fantastic job in continuing this trial, and for me, it's a big example in how to struggle yourself into a pragmatic trial.
Beautifully said.
Yeah.
Listen,
Can I make a point?
Please.
Also, because I think Roland is right on point, because when I prepared for today, I had to just look up that the average Dane eats 10 grams of salt a day.
Wow.
So it is really, and our health authorities are not happy, and we are advised to eat less salt. But at least it's so, maybe if the comparison had been to a sort of normal sodium intake on a sort of population level, then maybe the benefits would have been more obvious. But Roland is also can extrapolate more on that, because you're both the salt guy and also the fluid restriction guy, doing trials where you have to compare it to normal intake, I would say. But I think the fact that you use a menu-based intervention is the important thing, because even if you do show that salt reduction is better, then how can you implement a very strict... This is my youngest one. How can you implement a very strict diet if you can't implement it in real life? Then what did your study show?
That's right. That's right. So it'll be very interesting maybe to replicate this in Denmark or in the United States. I guarantee the sodium intake is extraordinarily much higher than what was seen in this study in the baseline group, for sure.
Dr. Wiseman, I just want to mention
Please.
to our residents how it is important to go into the details of these studies, because I encountered a friend who mentioned that there is no limitation in salt. There is no restriction. So, he was using this as an evidence, but going into the details of the study, we understand that as Dr. Kimmenade mentioned, it is basically comparing very low with low salt sodium restriction. So this is something to be careful about.
Absolutely true. It is interesting that the ones who were in the lower end seem to have a high KCCQ score. They did better. They were, and I don't know what's to explain that. I would imagine why that was. I don't know. Although that was not the primary outcome, it was a secondary outcome, I think.
And it's pretty consistent with prior studies, which showed like there's some benefit with the NIHA functional class and some symptomatic improvement in quality of life.
Interesting. Very good. All right, guys. This has been awesome discussion. Let's go to our last article.
Okay.
And thank you, Dr. Jean-Pierre. The average sodium intake in the United States, 3,400 milligrams per day. That seems low even.
Probably is. It's average.
That's true. Good point. All right.
Okay, are we able to see my slides?
We see them perfectly. Thank you.
Awesome. Hi, everybody. My name is Madiha. I'm a PGY3 at MedStar Baltimore. I think we talked a lot about the salt. Now it's time to talk about the water restriction as well. So I'm going to talk about the Fresh Up study, the liberal fluid intake versus the fluid restriction in chronic heart failure.
Nope, did we lose her? Dr. Kiani? I think that everyone else would lose her as well.
Yeah.
Yeah, it looks like she froze.
She froze. Nadia, looks like you froze. I'm not sure if it's a connection issue.
Anyone has their cell, you could text her. Maybe.
Yeah, let me go get her.
I may, in the meantime, share the QR code while we're getting back MHIM. So I'm just gonna share. Please scan the QR code for Maryland ACP survey and give us your feedback about how the survey is. You can keep it on your cell phone until the end of the session and send us your response at the end.
She's coming on. She just had to reconnect.
Sure.
I'm going to reconnect my slides again.
Thank you.
Okay, are the slides visible?
Not yet.
Mm,
Yes.
There we go.
okay, awesome. Let me just start the slideshow.
Thank you.
Okay. So the background of the study, so it's an investigator-initiated, multi-center randomized open-label clinical trial. Location-wise, 7 sites in the Netherlands were covered, and the time duration was from May 2021 to June 2024. Objective was to assess the effects of liberal versus restrictive fluid regimen in patients with chronic heart failure in the outpatient settings. And the patients, the inclusion criteria, the diagnosis of the heart failure as per ESC guidelines was more than 6 months prior to randomization. And all the patients who had NYHA class 2 or 3 symptoms were included, and of course, all adult patients only. Some of the exclusion criteria which were used in this study, all the reversible causes of heart failure, chronic heart failure with class 1 or class 4 symptoms, sodium less than 130, GFR less than 30, and changes in heart failure medical therapy, the GDMT, in past 14 days prior to randomization were also excluded. People who had scheduled cardiac surgery within the last 3 months were also excluded. And recent heart failure hospitalizations, PCI, CABG, these patients were also excluded. Apart from that, if patients had life expectancy generally less than 6 months, they were also excluded. And of course, people who were not able to give informed consent were also excluded. And the primary outcome which was seen in this study was the quality of life at 3 months, which is assessed by the Kansas City Cardiomyopathy Questionnaire, overall summary score. And it's the main outcome which was seen here. It's basically a standardized 23-item patient-reported outcome measure for overall functional status in patients with heart failure. It basically correlates with the frequency of symptoms, burden, and the functionality of how patients are living their life. And it's a very valid and sensitive tool which has been used in a lot of different studies. And scores are basically transformed to a range of 0 to 100. From like 0 to 24, it's like generally a very poor score. And as you go higher, like 75 to 100, it's a good to excellent score. And this is also a very good description of how the score works. So there are basically the main one, which was the primary outcome, was the KCC OSS, the overall summary score, which includes the symptoms, functional limitations, and quality of life. But all this other scores, which were the KCCQ clinical summary scale and the self-efficacy scale, were part of the secondary outcomes. Key secondary outcomes also included the thirst distress as assessed by thirst distress scale for patients. It also assessed quality of life by the other KCC, CSS, and the other KCC domains. And quality of life at 3 months as assessed by a visual analog scale was also used. They also measured serum biomarkers like NT-proBNP, sodium, and osmolality as well. And the occurrence of adverse events during the 6-month follow-up. Which included the all-cause and heart failure hospitalizations and need for IV loop diuretics as well as acute kidney injury. If we talk about the study protocol, so all the patients were outpatient, of course. Screening eligibility was checked and the consents were taken. 506 patients were considered to be randomized originally into two groups. 253 were in the liberal fluid intake and the 253 were the fluid restricted. And at the first thing that they saw was the week 6 patient reported fluid intake, that how much they were really actually drinking. And at 3 months, they basically assessed the quality of life, and that was the actual protocol. The advice that was given to the patients in the both groups, the fluid restriction group, of course, they were assigned to basically drink a maximum of 1500 ml fluid per day. They were told like the tips to basically work on if they feel thirst. And then the liberal fluid intake group, they basically were allowed to drink as much they wanted or whatever their normal drinking habits were. And this is the patient enrollment and follow-up. So screening, again, there were 524 patients, and then 254 people were basically in the liberal group, and fluid restriction group had 250 patients. There were some people who basically failed the screening process. If we see the liberal fluid intake group, 12 people were basically not able to complete or come to the visit, which was the primary endpoint. So actually 242 patients from the liberal fluid intake were able to come at the month 3. And from the restricted side, at month 3, only 233 patients were able to come. And actually 6 patients were reported to be non-adherent to the fluid restriction. And if we see the 6-month outcome, we see that from the 254, all of those patients were able to report the secondary outcomes. And from the restricted group, 249 were able to complete. Only one patient basically was not able to. Study was really high validity. Follow-up was complete, low attrition rate with almost 93% follow-up. Only 12 patients from the 254 from the liberal group and the 17 from 250 of the restricted were not able to complete the primary endpoint. And study was valid as well because it's an open label trial inherent to the type of intervention. Both investigator and the treating physician and the subject were not blinding. The lead investigators, members of the event adjudication committee, and the statistician performing the primary analysis were blinded for randomization and had no direct access to the source data. So this is the baseline of the patients basically who were randomized. If we see most of the baseline characteristics, which includes the age, the sex, the quality of life, the baseline, NYHA class 2 or 3, and then their ejection fractions, and they were either heart failure with reduced ejection fraction or mildly reduced or HFpEF. They were all fairly similar on the both sides. The only 3 things which were kind of different on the baseline were the use of the RAS inhibitors and the ARNIs specifically, and also patients who had atrial fibrillation. So these 3 were the main baseline characteristics which were slightly different. And as we move on towards the results of the study, so basically the primary outcome, as we mentioned, the KCC OSS score, in the liberal fluid intake group, it was 74, and in the fluid restricted group, it was 72.2 with a p-value of 0.056. The other key secondary outcomes, the main one that they looked at was the thirst distress. So 16.9 in the liberal fluid intake as compared to 18.6 in the fluid restricted group, and the p-value was less than 0.001. The other secondary outcomes all had pretty much less than 0.05 p-values as well. So the primary outcome, KCC-Q OSS, after 3 months was 74 in the liberal fluid intake group versus 72 in the fluid restricted group, with a mean difference after adjustment for the baseline scores of 2.17, and the KCC OSS values, as mentioned here, are here. So the primary outcome, the difference was just 2.17. Unfortunately, it narrowly missed the statistical significance. The p-value was greater than 0.05. Precision was fair. Narrow confidence intervals suggest consistent estimates. It's not statistically significant as 6 patients from the restricted group left the study. The key secondary outcome, the thirst distress scale. So the liberal group, as already mentioned, had 16.9, and the restricted group had it worse at 18.6, and it was statistically significant. P-value was less than 0.001. So liberal intake actually led to less thirst distress. So overall, what we found from the study was in patients who adhered to the fluid regimen that was assigned to them, the liberal fluid people who were on the liberal side, they had less thirst and they had better heart failure specific health status, which we saw through the KCC scores. And overall, the trend was better KCC scores in this group. And there were no major safety signals or quality of life disadvantages that were observed. So I think the whole thing about the fluid restriction and the salt restriction when it comes to all these trials is that we see all these patients in the outpatient settings, and we normally have this habit of restricting fluid and also the salt. So the question is, like, in coming times, are we able to really tell the patients that you can actually drink as much as you want, or still we have more studies and more trials waiting for us? And I'm really glad that Dr. Roland is here, and we can actually get some more information from him as well.
Yes, thank you so much, Dr. Kiani. And Dr. Kimmenade, would love to hear your take on this. I think people just don't like to be fluid restricted, is what I get that. That's pretty miserable. So we should stop that practice?
Yeah, well, I think actually you should put it the other way around. What is the evidence that you should put a patient on a fluid restriction? Because actually there is no evidence at all to put a patient on fluid restriction. And actually physiological data actually show that there is no reason to put a patient on fluid restriction, because if you drink 2 liters per day, only 167 mLs during this 24 hours will be in your intravascular space, which is the key for developing acute heart failure. And even then, if you have 167 mLs in your intravascular space, most of it can be buffered within minutes in your splanchnic bed. So only 50 mLs of fluid will be added to your intravascular space if you drink 2,000 mLs per day, while your kidney can easily filter 180 liters per 24 hours. So conceptually, there is no reason to do so. There is no evidence to do so, but somehow there is the intuitive assumption that you shouldn't do it. And this is why this has been advised for decades. What I actually also would like to mention is there is a very interesting study performed by nephrologists looking at patients with a moderate decline in GFR, 60 mLs. And during 1 year, patients were advised to drink 1 liter extra per day, comparing to their normal intake. So patients were followed for a week, monitored how much they drank, and they were advised to drink 1 liter extra. And what is interesting is that by the end of the study, the GFR, as mentioned, as calculated by creatinine clearance, was actually better in those who drink something extra, 1 liter extra. They didn't actually succeeded in drinking 1,000 mLs per day, actually only 600 mLs, but they also looked at antidiuretic hormone levels, and you saw that they were clearly lower in those who drank extra water. And antidiuretic hormone is another name for vasopressin, and vasopressin levels are, you don't want your vasopressin levels to be elevated in patients with heart failure. So I think if you look at the other way, there is, you could say that a fluid restriction should be advised because there is no harm, but actually there is as much evidence to suggest it's even harmful rather than beneficial. So I think that, like Einstein said, the most important thing is to never stop questioning. And this is also regarding your daily advices, and look at the background scientific evidence. And if your patient really meets the evidence that this is available.
Well said. Very well said. There's some questions that have been going through in the chat regarding this study. And
Wiseman, can I ask Media, please stop slide sharing? Thank you very much. I'm going to share the QR code while we're ACP answering the questions. Thank you so much.
Absolutely. If people could answer that QR code, would be great. And so there is probably some patients that we've all come across that may benefit from a fluid restriction, and then we kind of know maybe who those folks are, but it appears from this study, the vast majority of patients with heart failure, class 2 or 3, just don't seem to gain a benefit from that. There was a question in the chat about, do we know anything about the readmission rate?
Yeah, so we of course also looked into that, and this is why we did the fluid restriction. If the randomization phase was for 3 months, and we followed patients an extra 3 months just not to miss any safety events, and there was no significant difference at all after 6 months.
Fascinating. Fascinating. Wonderful stuff. I'd like to open it up for final comments, questions for our guests, and I really appreciate the participation we've had today from our residents. This has been just amazing. And to coordinate this, Dr. Forgahi, God bless you, sir. Amazing job. This was no easy task. Dr. Glargaard, Dr. Kimmenade, any final words for our young doctors in training?
Well, I would repeat my my advice, which I just said: never stop questioning. Also, my study.
Great advice. Great advice.
Yeah, and I think to follow that, the basic for the study question was actually a very good question from a resident to my for the PI of the study, my consultant Jens Jakob Thune, and it was a resident who asked him, so should I tap it? Should I pill a puncture? So even a resident, it's usually the ones that ask the good questions. And I know, Roland, you have shared before that it actually was a patient that asked one of your colleagues, what is the evidence that I should not drink any more water? So, and then I think it's very important to figure out if the question is good, and also figure out what is the best way, what is the best method to answer this question, and really be true to try to do a design that is both can answer the question, but also can sort of translate into a real world practice.
Absolutely. And I think these studies just demonstrate how clinicians can be investigators and researchers at the same time. And these pragmatic study designs are the future, and in a wonderful way to get evidence out there. And we can't thank you guys enough. This is not easy. Putting together these studies, I know, is excruciating, to say the least. I heard that before. So we thank you so much for your contributions to science and to us for being here today. We can't thank you enough. And Colleen, any final words from ACP?
This was fabulous. Thank you so much to everybody who worked so hard to put it together. Love it. Till next time.
Thank you all. Please answer that QR code. That helps us out in planning for future events. This has been just a wonderful experience. Thank you all very much, and have a wonderful day and a wonderful night, guys.